So hello and welcome everyone. I'm Rosemary Ford, National Council on Interpreting in Healthcare Director at Large, and I'm honored to serve as today's moderator. Today's webinar is brought to you by NCIHC's On the Road work group, Safety and Patient Experience Across Languages. This discussion addresses topics that are both timely and essential. As legislation and policy around language access continues to shift, healthcare institutes are navigating uncertainty. But what remains constant is the need for clear language-concordant communication to ensure patient safety, provider well-being, and equitable care. We're fortunate to be joined by a panel of distinguished experts who bring deep experience from clinical care, research, policy, and advocacy. They'll share practical strategies and valuable insights for strengthening language access programs, even in the face of regulatory ambiguity. Whether you're working on the front lines, managing services, or shaping policy, we hope you leave today's discussion with inspiration, clarity, and actionable takeaways. Thank you all for being here. And with that, let's meet our panelists. We have Dr. Michael Pasharlo, who is a physician, researcher, and CCHI commissioner. Professor Allison Squires, who is also the director of the Global Consortium on Nursing and Midwifery Studies, and Michael Ponte-Zins, who is the lead analyst in the Center for Patient and Family Experience at Cincinnati Children's Hospital. For individuals' full bios, please visit the NCIHC website. A big thank you today to our ASL interpreters who are providing communication access. So let's dive in. So we know with the Executive Order 14224, there's lots of misunderstandings and uncertainty. So for organizations who are hesitant to continue providing comprehensive language services due to misunderstandings around the Executive Order, what leverage can language access managers use to advocate the services provided are not watered down? Who'd like to start?
I'll dive in.
Sure.
Hi, everyone. I am Allison Squires. I am also a bilingual nurse by learning, not by heritage. I'm a fluent Spanish speaker. And I'm also a health services researcher, and I specialize at looking at language barriers at the point of care, particularly with nurses. So the first response, I think, to this, for any organization should really be to look at the impact on patient outcomes. There is an extensive literature, and this has grown exponentially since the COVID pandemic in particular, about the impact that a language barrier has on patient outcomes. So we know that people who have a language barrier, and this of course includes deaf persons who use sign language to communicate, they have higher rates of readmission. They also have higher rates of nosocomial infections. They're at higher risk for falls. They're at higher risk for surgical complications, especially those associated with communication errors. They're more likely to have a longer length of stay. And there are two others, unfortunately, that I cannot remember. But the critical thing is, if you're not using an interpreter to help you communicate and facilitating that experience during, in particular, a hospitalization, you are going to have a lot of problems in terms of readmissions, because those readmission penalties are still there. They haven't gone away. So we start with the place that that hits people the most, which is the pocketbook. So the organization runs a high risk for being penalized. And the other thing to remember is People with language barriers are actually, many of them aren't legal residents here in the US. They are also people who have become naturalized citizens. And for whatever reason, many of them still prefer to communicate in their first language. So this is an important thing, is you're denying US citizens the right to communicate, to a safe communication during their healthcare experience, if you are not providing an interpreter at the point of care.
So maybe just to continue with that thread, Allison, I agree with everything you just said. I think a key thing for language access advocates to do is to build alliances. There's really going to be a lot of threat from a lot of directions, and one of them is to build alliances with the providers. And I think if you find that the providers are relating to you as if you're a tool, then you have a high risk to being replaced by a tool. Most providers actually can get more satisfaction with having relationships with you, with having a team connection with you. But if that's not happening, then you're putting yourself at risk. And if they know they can provide better care with you, don't let them be embarrassed and pretend like that's not the case. They're at high risk themselves for providing bad care without your help and without your team membership. And so you have to speak up to build alliances. You can't be shy at this time. I don't know if that's dire enough, but I'm certainly feeling it.
I would completely agree with everything Allison and Michael just said. And from a patient and family experience standpoint, the #1 driver of experience for families, regardless of what language they speak, is communication. And communication is, as we all know, much more difficult when the provider speaks a language that is different from the patient and family. And so I just have a couple of numbers that go right along with what Allison was saying. For readmission rates, patients who give us negative scores are 3 times more likely to be readmitted within 7 days than patients who give us positive scores from an experience perspective. So we see the correlations right there. We know it's driving worse outcomes, and we know how to provide better experiences. And I think something I don't have the data to back up, but I also think we all know that from an employee standpoint as well, it's a better experience as an employee when you can communicate with families, when you can communicate with patients. So making sure that we have everything we need to properly and effectively communicate, I think is the right thing to do all the way around.
Yeah, and the data piece is key. And, most hospitals now have much better data capability than they ever did before, thanks to the electronic health record. But even if you don't have a research background or don't understand the data, you know what variables are important. So one of the things that you can do is reach out to researchers like myself, or they may be within your organization, even if they're outside of your organization. You can reach out to them and they can help you figure out what variables, what data do you need to pull from the system to help show the importance and the effectiveness of interpreters, just reinforcing that. Another point I'd like to make to build on what Michael was saying is, if you find ways to make interpreter access easy, people will use it. So I currently have a study going where we're looking at the impact of language barriers on hospital nursing practice. Believe it or not, this hadn't been done before. So it's sort of astonishing that it's taken this long. But one of the things that's come out from our interviews is that in one health system, they had adopted a product that made it really, really easy for nurses to use interpreters and access interpreters, whether it was in person or whether it was by video or audio. And so because it was so easy for nurses to access it, and the documentation was also integrated into the EHR, first of all, they were incredibly satisfied with it. Also, their use rate went up by almost 300%, which is amazing in itself. And it really shows that if there's a point, we want to be able to, if it's easy, the nurses will use it, and so will other healthcare providers. So, if you can think about the system ways to make it easier to access interpreters, it's a great way to go. And this is as simple as you can go to the different patient care units in a hospital and talk to people. You can talk to people in the clinics. And the other thing that the data will do is it will help you determine demand for interpreter services. Like if your population that you're serving, if the majority of them are Spanish speakers, obviously it's probably a good idea to have a full-time Spanish speaker as an interpreter in a specific location. And once you can establish the demand by language, then that can help you differentiate. Do we need an in-person interpreter? Can we rely on, or can we rely on video or telephone interpreting?
And as was mentioned during this discussion, Dr. Pasha Arlo was talking about tools that providers can use. So one tool I think we've heard a time or two is the expansion of AI in healthcare, and not all tools are created equal. So what are the main reasons why AI is not a fitting solution?
Well, there's a lot here to unpack. This is a bit of a complex topic. For myself, my own research has focused a lot on health literacy. That's been like a big topic. Communication is challenging even when there aren't language barriers. Clinicians frequently lose track and talk in jargon all the time, actually. But all this gets compounded, and it's even harder when there's also a language barrier. And so in my work, the clinicians that I talk to, and not just doctors, across the whole continuum of care, if I say to them, "Hey, would it be okay if the interpreter told you that the patient didn't understand what you were saying?" And everybody says, "Of course, if I'm missing the boat, like, of course, tell me that that I'm missing. But like, how, if I don't know, then like, I'm going to really miss it." Now, so in a way, I regard the interpreter as a health literacy advocate. AI cannot do this. AI is not there for this. Doesn't have this. I'm going to stop and let the other panelists mention their biggest pet peeve with AI. That's only one of them for me. So I hope I get another crack at this topic, but please.
Michael, why don't you go next?
Okay. So I'll start with saying that I'm someone who loves AI. I use AI almost every day in my job, but I think it's really great for very specific things. So if it helps me be more productive, if it helps me do things I couldn't normally do, then it's great. But as someone who deals with patient and family experience surveys and talking with patients and families in my day-to-day job, there's a lot of nuance in language that AI isn't able to capture. So we send out our survey to almost 1 million families every single year, and we hear back from about 9,000 families that speak languages other than English. And one of the things that we've learned very quickly is the wording for questions is extremely important in interpreting the results of those questions. And if you don't have someone who understands those nuances, it can really affect how you're going to interpret the responses. And so one of the things that we learned very early on with this was when we asked the question about safety, when we talked to our Spanish-speaking patient and family advisory council, they immediately came back and were like, "Well, what do you mean by safety? Is it emotional safety? Is it physical safety? How does the current administration and political challenges impacting safety?" And using AI to translate that wouldn't be something that wouldn't be able to capture all of that. So that's where we've really found that partnering with our language access services team has really helped us work through to make sure that what we're asking families and what we're learning from families is what we are meaning to learn, what we want to understand. But we do use AI and all sorts of tools across our hospital. So we have AI scribes that listen in and help take notes in my charts. Right now, I believe those are only being used for families that speak English. And then we do know that for things like my charts, that's only available in English and Spanish, that some families are using the in-browser translation to translate that. And there's obviously some challenges that come along with that. But as of now, there's some limitations with technology that are impacting how much we can provide to our patients and families. And so that's something I think that we want to continually be aware of, is making sure that technology isn't further driving some of those disparities in health and experience and outcomes.
All right, I've got a few points here. So first one is legally. There is no authorized AI that has been approved by anywhere to interpret. So that's the first thing. The second thing is AI can't pick up on body language the way that an interpreter can pick up, and that body language is really important to be able to do that. And also thinking about different accents. So I learned Spanish in Mexico, and my accent is more Mexican. My understanding of comfort level is more with Mexican Spanish. When I moved to New York, where it's predominantly Dominican and Puerto Rican Spanish, that's a very different accent. It took me time to adjust to speaking that. But it was also, there are different slang words across even the same language for different body parts that we know about. AI would need to be trained on all of those models. And this is what's important, is to understand how AI gets trained. So AI gets trained off of text-based models. So I'm sure there's technology that is going to be able to capture video and turn that into text somehow. But right now they get trained off of text. And to be able to train off of text, that means interpreting calls would have to be recorded and then fed into the AI to train the AI on how to be an interpreter. And so that would actually take quite a bit of effort, because the only way to do that in a real time and capture real life scenarios, and this would need to be millions of scenarios given the numbers of languages and different situations, and especially around different specialties in healthcare, then these would have to be recorded with the consent of the patient and the healthcare system and the clinician interaction. And when that is being done, whoever was doing that would have to figure out, how are you going to address when it's clear that there might be a situation where there might be like a clinical practice error or something that would warrant, a patient safety issue. So, it seems like, you can blow it up. Oh yeah, AI, that'll take care of it. It'll be no problem. And the answer is, well, eventually, maybe. Because to be able to do it well and to be able to do it safely would require a lot of training of these models. And that's going to take a lot of time, and it would have to occur through a situation where there was an agreed upon agreement between the AI developer and whoever's recording the interpreter interactions and the health system. So I could see a situation where there might be some companies who are, quote, recording interpreter interactions with patients for training purposes, but I'm curious if those training purposes include training for AI. So that would be something to get very clear in any type of contractual or legal agreement as to whether or not these interactions could be used for AI training. I don't think training purposes covers the training of large language models. So this would be a really important thing to check out with AI. At the same time, there are situations where the existing AI could be really useful in urgent situations, or situations where it may not be complex. And any situation could end up being complex, especially if it's in a hospital. But if we're talking a basic interaction where the patient's like, I just like some water, do we need to call an interpreter for that type of information, or could something be used on a phone? because there are levels of interaction that would probably be safe for communication, but those haven't been defined yet. So that's the tricky part, is it hasn't been defined. The only thing that's been defined clearly is that you can use an AI in an emergency situation, an AI interpreter in an emergency situation, but you have to record that entire interaction and have an interpreter check it for accuracy afterwards in order to be in compliance with the law. Civil rights law still stands, so all of these protections are still there regardless of executive orders that have been made. So the provider is who's relying on that, but if there's an error, could still be subject to a civil lawsuit. And reminder to providers who are watching this, you probably didn't know this, but it's not covered by malpractice insurance. Civil lawsuits aren't covered by malpractice insurance. So that's a totally different legal avenue and exposes you to a different level of risk.
I just want to pick up on some of the themes and maybe to call out a few things explicitly. Sometimes the cultural brokering that's done by the interpreter is done very subtly. You know, it's actually done kind of in the interpreter's process, you know, between the parties. I actually think it would be reasonable to be a little more explicit with the providers. It's reasonable for them to be viewing the added benefit that you're bringing in the room as a human being, because actually they're thinking about replacing you with AI, and or their bosses are. And so that some of that cultural brokering is like part of, there are multiple comments in the chat about that relate to this, and it's come up a little bit, but that's clearly part of the scope of practice for interpreters, and but sometimes is not really quite viewable to the patient or to the provider, because it's just being facilitated. Another one that really I think deserves getting called out is emotional communication, and it's kind of been implied but just to explicitly say, and this is another area where it's not just nuance and context, but other layers of stigma, cultural context as well plays out. How people communicate about these things is highly dependent on many factors, who's in the room, all kinds of things. And this too sometimes is a little too subtle. And I really, it might sound odd because it might be different than what you're used to, but I wouldn't be shy about it. Let the providers see that you're being a human being and not a machine. And one of those factors is the emotional channel.
Great points on there. So what strategies can interpreters and language access managers implement to impress the importance of the continued utilization of qualified medical interpreters?
Well, I have some data that I think speaks directly to that from our patients and families. As I was saying earlier, we hear from about 9,000 families every single year that speak languages other than English. And consistently across the board, we see lower scores for communication and it's pretty significant margins. So 20 to 30 percentage points lower for families that speak languages other than English. And we've already spoken to how important communication is in driving experience, driving outcomes, and driving safety for our patients. So I think that data right there shows you that having qualified interpreters is extremely important.
Yeah, just reinforcing the data. And, if this is new data that your organization needs to collect, you want to have it be not only within your language services department, you want to have representatives from the different professions who are engaging with and using the data and coming up with a systematic quality improvement strategy to be able to make sure that you're optimizing the use of language services in the best way possible. And, one way to think about this is, you want data about planned encounters, things that can be scheduled, like, while primary, no doctor's office visit runs on time, but you can actually plan to have an interpreter there, have a person be scheduled for a visit. And, that's very different from an unplanned encounter, which may happen more in the hospital setting, where someone's come into an emergency room or someone's been admitted to a floor and, you need to, and that person's coming up. Surgery is largely, surgical and procedures is largely a planned event for the most part. Interpreters could be scheduled there. So it's thinking about how can you improve utilization and deployment of interpreters for both planned and unplanned encounters.
There's a lot of topics here. It really depends on the type of institution, the size of the institution, the size of the staff, and all kinds of things like this. I don't want to sound hokey, but you actually can have coffee with providers and become human beings together. Like teammates actually do things together so that gets concretized. There's a lot of institutions that don't do this very well, even say between the doctors and nurses, like different little sub-societies of the institution. Those hospitals have safety risks. Team safety culture is a relevant part of this, but you have to find the metrics that are relevant to the different parts of the institution. So, Michael, excellent data, relevant data about satisfaction. You might actually have to make sure that your institution collects satisfaction data in other languages. If they're only sending out their survey in English, you're going to systematically not report about the satisfaction of your non-English speaking patient population. In most places, even if they do send it out in other languages, the response rate is much lower in non-English speaking users of the institution. But I would say that in some places where I've worked, I've been able to get clinicians and interpreters to have monthly coffee together to start to develop the connections. And I feel like once the relationship actually is developing, then you see actually how much further you can go. The patients and the interpreters often know each other longitudinally. Like that's like, so it works at both levels, but also the providers and the interpreters also can know each other. So like it doesn't have to be, you don't have to be a tool. You can actually be a member of the team.
Right. And, I think there's a lot of engagement around interprofessional collaboration. There's research dollars that fund this, it's still funding it even now. But it's a good way to keep language access is by, figuring out what would be great interprofessional team models. And you can work with researchers who specialize in this. That helps to build the relationships as well. I will say it's a little hard to pull a nurse off the floor for coffee for any prolonged period of time, but engaging more with the nursing department is really critical because they're going to be your highest volume of users of interpreter services if it's easy to access on the inpatient side. So I agree with Michael about the relationship building. Do it in whatever way that you can. And, I'm thinking back to, I worked in Nebraska for 2 years with a critical access hospital. It's, those are only 26 beds, but it was in a community that had a population that was 60% Latino and Hispanic, and another 10% that were predominantly a Somali immigrant population, but also there were 10 other West African countries represented that were working locally. So the hospital just decided we're hiring an interpreter to be there full-time 24/7 for Spanish and at least during the day for Somali. And so it's one of those things where they just decided this was important for their community relations and sustaining a good, positive relationship with the community. And that's a situation where they're a market monopoly. The nearest facility is an hour drive, the larger facility is an hour drive away. And so people don't want to go that far for their healthcare if they don't have to.
Yeah, but each part of the institution may have their own metrics of concern. Another type of an example that hasn't quite come up yet is like the emergency room cares about the throughput time. Not having interpreters leads to more testing and longer stay in the ED. That was one of the data points maybe that was on your list, Allison, that you didn't get to.
Yes.
But unnecessary testing is not good for anybody, but the emergency department cares, for their throughput time. So everybody has their own metrics, like, the outpatient clinics, like their HEDIS measures, like everyone has their own things, but you may not be in a market that wants to compete on satisfaction or, that part of it. But it's great. Actually, Allison, I was great to hear about a critical access hospital that did care about satisfaction and community relations. It's not always the case. So,
Right.
That's fantastic. I want to bring up another thing. I think someone earlier up on the chat brought up the Marina or somebody brought up something about ethics. Ethical judgment is not something that AI is trained for. It'd be a whole nother conversation about like how and exactly all the different ways that the interpreter can have a role in ethical judgment. And of course you can, you're sitting with the provider many times who's a mandatory reporter. And actually, if the rapport is good and the connection is good, like you could be clued into that or not. So, I think interpreters, it makes sense to lean towards the higher part of your skill set. So that people can see the value. And one of those would be to, lean towards this as well. There's no AI ethical judgment.
Yeah, I think based on everything we've just heard, we can make a really strong multi-pronged argument for the importance of having a strong interpreter services team from the standpoint of the patients and families, from the standpoint of employees. It can have financial benefits through the throughput in the ED or same in outpatient clinics. So I think that depending on who you're talking to, there's a variety of different factors that you can have at your disposal to push for this. And as Michael was saying, having those relationships with everyone, if you have the clinical staff who are saying at the same time, this is really important, and then you have some of the management on the language access services team saying this is really important, and having that come from multiple different directions, I think will go a really long way in convincing the hospital leadership of the value as well.
Actually, I'm gonna say something a little more, slightly different type of a thing about community relations. If the providers are treating the interpreters like badly, like tools, if the providers are treating them, if they're ignoring them and treating them bad, that will get communicated to the patients. Not like they're not sitting there necessarily saying, "Oh, they treated me badly, they're treating me badly," but actually, messages get communicated one way or the other. It's been mentioned that I do a lot of research, and so actually I've done programs to work with interpreters to learn about research. Like, why do I care about research, and why do I care? Why do I think it's a public good? And most of the interpreters that I've done with, no one ever talked with them about research before. No one explained, no one has said what are your concerns? What are your worries? If you don't actually process these things, because we're talking about human beings, like they all have their own concerns and their own worries and their own misgivings and their own fears. Are you doing experiments on my community? Like, what is going on here? And so if you don't actually treat people well, it will get communicated. Your goals will not be met as a provider. So it's actually really very much in their interest, but they just sometimes don't know it, and it's a little too convenient to treat interpreters like tools, and they're falling into a big hole if they go there. I think they really will turn around and be sad. Let me just put it back to another thing, which because both Michael, you mentioned how you use AI all the time. About 20 plus years ago, I went to the hospital and I said, you know, we don't have any access to interpreters on a regular basis. Like we can have somebody once a day, and you know, and no one ever picks up the phone. It takes too long, and when we call, so I made a little ring, a little set of cards on a ring, and on one side it had an English word, on the other side it had, you know, what the in the other language. I'm cold, I need a blanket, or I'm thirsty, you know, a whole set of cards. And they said, oh, you can use this, except for one card. There was one card in the stack that they wouldn't let me use. And that card said, I need an interpreter, right? So the system is not set up for humane care. It's not. We have to fight for it all the time. You know, if the card they wouldn't let me use was I need an interpreter, because what they wanted was a convenient little fix, like the phone app that you referred to, or like the AI fix for something simple, like I need a blanket. Do you need a trained interpreter to come to say I need a blanket, you know? But the system is not set up for this. And a lot of the providers don't know how to fight for them, themselves don't know how to fight for it. They kind of make do with their broken Spanish or something like that.
Yeah.
Which is a great segue into my next question here. So Section 1557 of the Affordable Care Act requires that bilingual staff who wish to speak directly to patients be vetted in all languages spoken in order to be a, quote, qualified bilingual staff person. So what are some benefits of organizations investing in fluency testing for those who wish to be at the status?
Well, I can talk about early findings from my study. So what our bilingual nurses have said is they would love to get training, but their employer won't pay for it. And they feel like this is something that would be a benefit to the employer, and so that the employer should arrange for this training to be able to happen for them. And, you know, the nice thing about clinicians is they already come in with a lot of the medical vocabulary. It's just finding the matching language in whatever they're going to interpret. But there's also a sort of a caution there too, because once people know you can interpret, then, you know, people already they still get pulled in. We know this still happens to interpret if they're known to be cleared to speak another language. So it's one of these things where I think it should almost, if people are willing to do it, that healthcare organizations should do it. And then you're building in capacity within the organization of people who are experienced clinicians and have that perspective. And that just increases your pool, which especially in an emergency situation would really be beneficial to the patient, because, you know, oftentimes emergency situations, things can happen and change so quickly that you don't have time to wait for the interpreter to come.
Yeah, I think all of our organizations have employees who speak languages other than English fluently. And I think we should all be doing everything we can to make sure that those employees are in a position that they can accurately translate for our patients and families. And that does involve supporting the fluency testing for those employees and having as many employees as we can across our organization who are certified to translate only does positive things for those emergency situations that Allison was talking about. And then it also can take our interpreters and makes them a little bit less spread out across all the different interactions that we have.
I mean, I think it's obvious that it would be beneficial to diversify, culturally and linguistically diversify the healthcare workforce across the whole workforce. We're a long way from that, and you know, so that's not gonna happen very soon. We may be farther than that this year than we were last year, even, because you know, various programs that were promoting that idea have been defunded. But you know, it'd be awesome if JACO actually took this goal and made it more serious. You know, it's been talked about for years, and there is a program, of course, but it's not been well policed, and I don't know why.
I have heard though from colleagues who are still working in hospitals and are in administrative roles around Joint Commission. Joint Commission is actually, from what I'm hearing recently, they are paying a lot more attention to the language access issues. And so if you need an additional incentive, there is a possibility that your Joint Commission accreditation may be paying closer attention to that. Your State Department of Health who also is your other accrediting body for a facility, they could also be someone who investigates around language access, because a savvy consumer could report violations to the State Department of Health, which would trigger an investigation, especially if it resulted in harm to patients or were clear violations of patient safety.
So from experience within my healthcare organization, when we first rolled out the QBS, the Qualified Bilingual Staff Program, it did a few things. First, it did enforce the need for qualified interpreters, because we have had all kinds of clinical and non-clinical folks who said they were bilingual and proficient enough to communicate directly with patients. So once they were presented with a testing opportunity, it was a big aha moment for staff and a new appreciation for interpreters. And additionally, it was educational for many folks, because although they may be bilingual, they were not bilingual or fluent in medical terminology. So I did have lots of individuals come to me and say, okay, I thought that I was able to do this, and now I have a new deepened appreciation for the interpreting profession and what it contributes to my patient care.
Yes, I developed my fluency from living and working in Mexico for almost 3 years. And so I was always amused when people said, oh yeah, I speak Spanish. And then you hear them speak, I'm like, nah, not really, especially not medical Spanish.
Absolutely. And when we have these programs in place, there's also the regulations that you have to have. So if you have Joint Commission or DNV, you need to have proof of those competencies on file, because we don't use Joint Commission, we have DNV, but from recent experience, the accreditors come in and say, we'd like to see at least 5 patient records of patients who are LEP, and then they run tracers through that, and they're looking for documentation of working with an interpreter or some type of waiver process if the patient did do that, and then the qualifications of the interpreter or QBS who's providing either direct communication or working with a qualified medical interpreter. And that was of recent.
It's on people's radar, and in part because, I mean, this is an issue that's facing the entire country now, whether people like it or not. And, and importantly, and things to be really, to reinforce with people is this affects US citizens, and it affects people here with legal status. The xenophobia that's out there assumes that it's just people who are undocumented, who are coming in, who don't speak English and that kind of thing. It's not. 1 in 5 households in the US speaks a language other than English at home. And that stat is from the latest US Census, so 2020. And that's held steady. So, when it comes down to it, you're denying this to US citizens and people here legally. Ethically, it should be for everybody.
So there's always the pressure of budget constraints. How can we stretch the dollar further? And that affects interpreter services departments. And let's talk about how can the watering down of provisions on language services impact our limited English proficient populations when seeking healthcare services?
Well, I mean, there's so many bad things that can happen. Safety problems, of course, but people also just won't come, and this is a topic I think was brought up in the chat a few times, but we haven't really talked much about yet. But there's it can be scary to go to healthcare contexts even before you're worried about ICE. There are people who are legally here but still worry about ICE. There's and maybe reason to be in that scenario, and having someone that you can connect with linguistically and culturally, can make it a little safer. But that doesn't actually make the place safe completely, and there are people staying away. I have I still see patients in primary care, so we've been trying to pay attention to this, and it's already clear that some people are coming less. There was a whole period of time, during COVID, that we moved to video. Of course, there was a lot of appetite to get away from video and to come back to in person, but now there are preferentially people who want to be back on video so that they don't have to come in.
Yeah, and that point about video during COVID, I think it was COVID. Now, I've been following the language access literature for, for the 20 years I've been doing research. And what I find fascinating about COVID is I think the video-based telehealth care actually sensitized people more to the importance of interpreters, because they had to bring that interpreter in on that interaction for that telehealth interaction. Or if they didn't have that interpreter available because the systems didn't talk to each other or whatever, then that communication barrier became even more stark. So there's been a huge uptake or a huge uptick in the amount of research that's come out documenting the impact of language barriers across all points of care. I mean, everywhere. And so, that literature is growing. If work with a librarian, if you have access to that. If not, get to know somebody who does have access to it. And that literature can also be helpful to justify, the presence of a language services department in your facility. Now, there was a question in the Q&A about, should language services be involved with new employee onboarding? And the answer is absolutely. You will save yourselves a lot of headache in general, and you will increase the utilization of the members of your department and the services you provide if people know, first, that you exist, second, how to access you and access the services, and basically, however it works in your department. And then you all should become part of annual education. Work with the professional development people who do the continuing yet required annual education that everybody has to do, and become part of that. And, just remind people that, test their knowledge, make sure that they know what's going to be coming in terms of, what the latest legal requirements are. And, this is all stuff that can be done in collaboration with the quality improvement people, with legal, with the risk management people. This will actually make the risk management people a lot happier. So, think about those key points in an employee's lifespan when it's important for you all to engage, not just at that clinical encounter, but more broadly in terms of whatever's going on in the healthcare facility.
I want to bring up another topic. It's another role that sometimes people don't think about, that the interpreters are playing, or many interpreters are playing. And it's another reason why I agree with what you just said, Allison, which is that interpreters are also de facto community liaisons. So in many communities, especially in small language minorities, and especially in smaller place communities, but in many communities, Your interpreter staff are also community liaisons. So the patients have their phone numbers, and to talk with them in other contexts. It doesn't magically happen that the interpreter is available at the dentist and at the drugstore and at the physical therapist. And so, people have to figure out how to make their lives work. And many interpreters are de facto cultural, community liaisons in these different ways. And so involving your interpreters in all of the different ways the organization works, so that they understand how is the organization going to protect privacy if ICE comes? How is the organization going to try to make it a safe environment? The interpreters need to know this. It's not just like they get called in only like to see the patient when the patient if they know these things, it will also be spreading, because they're also members of these communities and talking to people. So this is just another layer of thinking about this person as a human being who lives in a place and has relationships with other people, and the patients know each other. Like, it doesn't have to be so mysterious, it's like another reason why risk management should care about keeping the interpreters in the loop.
Yeah. So I think we're all aware of, I think, the challenging financial environment that healthcare organizations are in, between the NIH cuts, the potential cuts in Medicaid that are coming. So unfortunately, I think that means that we can't be blind to the financial realities of the current world. And so I think anything that we can do to show the benefits of having interpreters available, I think would be really beneficial. And so I think there's and I don't know if this has been done yet, but I think there could be a really interesting research project around looking at the preventive care and the primary care, and seeing when there's interpreters available for that, how that then impacts health outcomes later on, to see if we are preventing costs for future admissions, for future surgeries, or future healthcare events that are costly. And I think that could be a great way to demonstrate that this is an investment that we're putting in right now, but we're looking for this to return further out. Because I think, unfortunately, no one likes to think about dollars and cents with all this, because, as we've said so many times, this is the ethically right thing to do. But unfortunately, given, the current environment we're in, I don't think we can ignore that.
I agree with you, Michael, on this, and I would just say, learn from the different stakeholders what metrics they're sensitive to. Some of these things are harder to put together. Like the long-term impact is going to be harder. It could be that the institution has shared risk contracts, and so that actually they have, metrics in population health, with HEDIS measures that they actually are, at risk for, and they could get actually a fair amount of money if they increase their mammogram rate and their pap smear rate and like colonoscopy rate and their A1C rate. And in many health systems, the lowest performers on these metrics are non-English speaking, and maybe it would help if you communicated with people in a language they understood. Because when you send a letter in English and it says, hey, have you gotten your mammogram? I mean, it doesn't work for everybody. So I think you're right, Michael. It's just sometimes you have to figure out, what is the sensitive metric for your audience.
Absolutely, completely agree.
And along those lines, from my experience, when we're looking at our community needs assessment, we can narrow it down to target populations who might be more vulnerable to different disease. And from that information, we can have targeted information and team with our interpreters to provide that education and outreach. And that can be by partnering with your public health department, using your social media channels, and providing, memes or videos, working with your interpreters, again, providing that information in a language that folks understand, but also doing that outreach at community events. So if you have, for example, where we have a Brazilian festival, we have a Latino festival. So we make sure that our organization is there, but we also have our interpreter services team there to meet the community, to be able to provide the outreach in the language that folks speak, and also have information available, printed information that's accessible for folks.
Yeah, and any printed information, this is where AI can be a real time saver. Like the translation quality for widely spoken languages has gotten really good. I mean, it's kind of amazing. It happened during COVID. Don't know what happened, but it just got really, really good. But you still need a human to check it. So, you know, I run a multinational study as one of my other research projects, and we're operating in 26 languages. The AI communication translation is terrible for languages of lesser diffusion. But for commonly spoken languages, it's still really good. So it's also understanding what's your local market and show, you know, okay, yeah, we can still do AI. This is going to save us time because it means we just have to check the translation now. But it also means it's much easier and much less costly to provide all of the printed documents in the languages that your patients speak. And, you know, you don't want staff going to Google Translate, putting in the discharge instructions and, you know, giving them to patients that way because nobody's checked them. But your staff are going to assume that Google Translate is accurate. And I'm not picking on Google for any reason. It's just something that we know lots of people use.
And along those lines, even if you're translating information and you are working with a qualified translation company, another opportunity is to bring your interpreters in. They're not qualified to translate, but to review the translation. Although it is done by an organization that is qualified, is it localized? Because your interpreters are going to know the jargon, the terminology that the local community is familiar with. And I've run into that on several occasions where we had to go back and say, well, this isn't going to do for our community. Here are the recommendations from our interpreting team, and then working together to make sure that the information that they're getting is relevant and within the dialect that's being spoken.
Just to add the next step, Allison, to what you were saying, which was on point, is also the patients will do it. You know, so if you give it to them in English, they'll put it into Google. Like, so, you know, it's happening one way or the other. If you don't provide services that are language appropriate, someone is going to have to figure out what to do, and the providers may put it into Google, or the patient may put it one way or the other. It's not the safe path. You know, so these tools are in everybody's hands now. It's as if it's like when the doctors like pretend like they're talking to a patient and they think that the patient hasn't already been on Google looking up all their issues. Like, of course they have. Like, everybody's doing this all the time now. It's just some of us are more open about that.
Then, you know, it does become the balance. AI is a tool. And like any tool, it needs to be used well. So, you know, you need to teach people how to use a tool appropriately. Like, you know, you got to teach people how to use a scalpel in order to do surgery and make incisions in the correct way. So, and you have to teach people how to insert an IV in order to make it, you know, in order to get it into the right place so it works the way it's supposed to. So I think, you know, thinking about AI as a tool and, you know, coming together and figure out what are the boundaries of when it's okay to use AI and when it's not. And it's not because there's a lot we don't know. And it's okay to say, we don't know what this can do yet. And we don't want to guess because people's lives are at stake and it's a patient safety threat.
Right. So people are going to say when if you go and say this to, you know, there's a problem with AI, the first thing they're going to say is, well, you know, it's going to be getting better. It's getting better all the time. And that's true. We did a study. It sounds like ancient news, but like about a year and a half ago, which we call Death by Siri. So we had patients asking Siri different medical questions, Alexa too. It wasn't just one system, other systems too. And, we just let them ask whatever they wanted, but in an observed environment so we could see how the interactions went. And people asked all kinds of interesting things like, how long can I ignore my doctor's advice about this medicine? Or like, how many drinks of alcohol can I actually have with my OxyContin? Like, all kinds of things that they would want to know. And at that point, all these systems were giving confabulations. They were making answers that were made up, that were hallucinations, that were falsehoods. And already between then and now, it's shifted. Most of the systems are now having have filters for this and say, please, talk with a doctor. But like a year and a half ago, it would make up a number, like how many drinks of alcohol you could have with your opioids, and it was all made up, and it had references too that were, they referred to papers that were also made up, and so things are getting better. So I bring this point up to say that people will always point to that. And in fact, they are getting better. It now says, please talk to a doctor. Don't take this as medical advice or whatever, blah, 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 blah. That's not where human interpreters are going to be able to differentiate themselves. It's not going to be on the speed of a massive hallucinated, bringing together of all the literature of the world. That AI is going to win every day. It's going to be on these other factors. Culture, emotion, rapport, context, all these other types of things that are about what humans do, actually very, very rapidly, and actually pretty well. People will say, oh, this AI system was more accurate when we did this comparison test, and this word was more consistently interpreted as the right word in this language. I don't care. That's not what's actually happening in these interactions. It actually, yes, trust. Thank you, Amanda,
Yes.
brought that up. Yes, excellent. Thank you. Another word that was super important in that context.
Right.
So, so finding ways to have all the stakeholders see that is going to be very important. And because I'm a provider, I worry about the providers not seeing that. So it's time for this to be just much more explicit.
Yeah, and Michael, I think doing all of my work in New York City, one of the most linguistically diverse places on the planet, providers are tuned into it, but it's the systems that have to be easy for them to use them. Everybody's aware, everybody, understands this, but if the interpreter services system is too difficult to access and too difficult to implement, and you're waiting too long to get an interpreter, the clinicians are not going to use it, even if they know how important it is. So that's something also to keep in mind as you're thinking about services, is how do we make this easy for the clinicians to access it? Because the research literature is really clear. Everybody prefers an in-person option if it's at all possible, followed very closely behind by video. And this is also important if we're thinking about older adults in the hospital who may be hard of hearing. The interpreter phone is really difficult to use when you've got someone hard of hearing. This has been coming out in my own study right now. And it's also really difficult if you have someone who's got a traumatic brain injury or neurological condition that affects their ability to communicate. They can't speak, they may understand in their language, and it's going to be really important that you have an interpreter present who can read the body language and try and get a sense of what the person's reaction is to that situation. So, given the growing population of older adults, the high probability that we're going to have more and more people who become hard of hearing as they age, this is another really important part. So, that in-person or video interpreter is going to be important because people do teach themselves how to lip read, whether they realize it or not.
So as we're talking about stakeholders, keep thinking about potential allies that we can gain relationships with. when we're referring to our colleagues in healthcare settings, who do you recommend that interpreters and communication access managers partner with as allies, and what are some key terms that should be used that will resonate with decision makers within an organization?
Michael, you want to dive in on that one?
You got a 50% chance. I'm going to go with Michael Ponte-Zins on that one.
Or the
That's
other
the
Mike.
best
Yeah, oh,
part.
yeah, that's
you
true.
can say either
That's
one. So as someone who works in patient and family experience, I think the patient and family experience team is a great team to partner with. As I said earlier, we have a really great relationship with our language access services team, which helps us. I think it helps both sides. We understand better what our families who don't speak English need to have a good experience in our institution. And we can also help provide our interpretive services team with more feedback. So we, in conjunction with them, recently added a question on our survey asking about the effectiveness of the interpretation so that we can get more feedback around how well we're doing interpreting and communicating with our families that speak languages other than English. As the other Michael had said earlier, partnering with your clinical teams, the doctors and nurses, is extremely important because they're the ones who you're interacting with on a daily basis in those clinical encounters. And so having a good relationship with the doctors and nurses, I think goes a really long way, just to make sure everyone's on the same page and make sure that, that's understanding, because there is, I think, there's two levels of communication that go on from the doctor to the interpreter and the interpreter to the patient. So I think that's a really important relationship to manage as well. And then obviously hospital leadership, they're the ones who make all these decisions. And so being in constant communication with them is extremely important to make sure that they understand the value that interpreters provide to families. And having everyone, that I just mentioned together, making that same case goes a really long way.
I agree with these points, and also there's several comments about other, good alliances to be made, social workers, other people who are committed to, patients' rights and patients, even and community relations like marketing and communication. I want to bring up another one that I think sometimes is not connected to, but I think could really be good because it has excellent visibility to leadership, which is quality improvement. So quality improvement in many institutions, they have different products, if you will, different things that they're doing. One of their products is in some institutions called M&M, in some institutions called root cause analysis, but effectively at some regular interval, in many institutions is monthly, but effectively they get to decide what are the topics for the year that they're going to highlight as part of the quality improvement work. And I would recommend that every year, one of their 12 monthly events focuses on a language access safety issue. Now, all of those things wrap up to someone in the executive team who is responsible for QI. Usually by, at least by JACO's organizational structure, there's a vice president for that. Just like there's one for the patient experience that Michael's group has to report up to. Sometimes at the chief nursing officer as well, whatever. But the quality team also reports up. And in order for this to happen, though, you need to have providers report incidents. Now, these incidents are happening all the time. It's just they're frequently underreported. Yeah. And then even when they are happening, the QI department looks at all the incidents and gets to decide what will they make as the public event for that month. So it's actually something that gets talked about and they get to choose. So you can actually go to QI and say, hey, we're the interpreter services department. We know that our work helps to reduce safety problems. Can we work together to have root cause analyses so we can figure out how to better support the institution to avoid these problems? And I suspect that there'll be an alliance that's worthy. Besides the fact that they then can have an event that features your services, their work gets rolled up to the executive leadership.
Yeah, and Michael Pascherlo, you read my mind. That was my next point, was the QI piece. Interpreter services should be part of QI teams across any facility. And so, and that is how this is affecting, in particular, patient safety. So that's really something to think about. And I realize that most of you are like stretched super thin and have way too much on your plates. But if you're talking about where to target your efforts and your energy, that is a low-hanging fruit that will bring high value to your department.
And speaking from experience, once you build the foundation, it's easier to build upon that. And don't wait to be invited. Ask.
Yeah.
Because we have something very similar. It's called the Quality Council, and we do annual audits within interpreter services, where we audit compliance with documentation and teaming with an interpreter, and then we present that data to the Quality Council, and they're all about it because, again, it reinforces patient safety, quality of care, and our mission as an organization. So reach out, ask, and the quality team, more often than not, they're willing to work with you so you are successful with presenting your data.
Yeah.
It's a plug for another angle, depending on the organization. If it's an organization that's active in research, you can ask at a high level, not in a particular granular level, but you can ask at the IRB level or at the research executive leadership level, what portion of the participants in research studies were not English speaking. You likely will find out that there's a significant underrepresentation of non-English speakers in research, and that this is another point of advocacy, and then also another set of stakeholders who can be supportive, and depending on your organization. When I work with companies, like drug companies who are leading, for drug trials, and they say, well, how many patients will you enroll in Spanish if we put the materials in Spanish? My answer is, well, if you don't do that, I will enroll nobody in Spanish. Okay, so give me a chance to do it, and then let me try to do it. But the advocacy for this goes in all directions. And if the institution is looking to grow its research portfolio for trials, which a lot of them are doing because NIH has become such a bad partner of late, then they'll be happy to see you coming because they need your help.
Yeah, and another thing that you can do from the quality angle is if, for languages where you're contracting with outside companies, and for those of you in external companies, this is for you too, but the data reporting standards they don't exist, but the data that's reported in terms of quality, in terms of overall interpreter performance, is terrible. Like, I've seen Excel spreadsheets that don't contain any useful information and that cannot be analyzed, which is a real problem if you're trying to hold somebody accountable for, doing an interpreter call when they're outside walking a dog in a noisy neighborhood, which, we've heard about, or people where the connection keeps dropping, or, people where it's clear that it sounds like they're in another country, and is it actually legal for someone in another country to interpret? If someone can answer that question, I'd appreciate it, because, they are outside of the legal regulations around HIPAA. and, and also protections against personal health information. So, these are all things to be thinking about in terms of the quality and the data reporting is how do you want to hold your vendors accountable in terms of the data that you expect them? Most of the time it's like, hey, was this a good call? Yes or no? And it's like, that doesn't tell me, it's just, was it good quality? It's like, did I have concerns about sound, about call being dropped, about the interpreter interaction or the quality of, it's also quality of interpretation. Did the patient look like, I don't think that's what they're actually saying, or did a family member say they didn't interpret that correctly? So, it's those types of things around, it's got to be that back and forth accountability of, to improve the quality of the interpreter experience as well.
Yeah, and I'll say I've found that 99.9% of all the people I've worked with over my years have been in this for the right thing. They want to make things better for our patients and our families. And so I think when you go in with a good faith, this is what I'm trying to do, you'll see a lot of people will be there to support you and will try to help you out. So I, encourage making, sometimes you have to take the initiative, and you have to go and start that conversation. But when you do, I think you'll more often than not be happy with the outcome.
I think we have time for one question before we wrap things up. So how can we provide language access to our patients when encountering events with third parties, such as CPS, police departments, etc., while protecting our in-house interpreters?
Oh, we have someone who's an expert. That's out of my area of expertise, but it looks like there's somebody who can answer that question.
Well, I will share as a policy writer within my organization that I have written into our policy for interpreter services and communication access that my staff interpreters are to interpret for our organization and for healthcare encounters. So if there is, for example, police, law enforcement that comes on site and needs to speak to a patient in regards to whatever they're investigating, our interpreters are not to interpret. It's not within their scope of practice. They're not qualified. None of my interpreters are legal interpreters. And we are able to provide them with resources as to where they can obtain one if they're not able to get one on their own. And that way we don't have to put anyone in an awkward situation that could potentially cause harm to whatever's being investigated or to the patient.
So I completely agree. I just want to point out, Vanessa posted a link to a recent guidance on this, and a bunch of different organizations contributed or provided comment. You guys, we did a lot of institutions or groups provided comment. I just want to reiterate, though, that fulfilling what you described, which I think is the right approach, Rosemary, it does require a fair amount of training for everybody, because like the clinicians need to understand this too, because the interpreter is going to be in a very tight spot if the clinician is not also trained and understands. So like in our institution, we basically had a standard rule: the interpreter stops and the provider is supposed to call security and just to say to law enforcement or whoever's there, "Oh, thank you for coming. My job is, I've been told to call security. They're going to come and facilitate the next step." And actually, so that, but it requires training. It requires reinforcing this. It's not necessarily easy, and people get nervous, they get upset, they get confused. And so this is the kind of thing that just requires training and reiteration, and you still may end up not doing it the way you were hoping to do it, because people get nervous and upset. And
yeah, tough questions.
Yeah.
Let me just check the chat one more time here. What is there? What if there is an interpreter working in a hospital who is already a legal interpreter? Can they interpret for the police or other legal interviews?
Well, in our institution, we said no, that the standard is to call security, and security would facilitate. As it turns out, the next step for security is to decide if they're going to call risk management, and then risk management can facilitate if they want to continue with that person, or whatever the next steps are. That's not what that person's role was in that room. Each institution is going to have to find their way on these matters. Maybe this is going to be more common going forward. But I have enjoyed the clarity of my institution's directive on this. It's easy. People get upset. It's good to have an easy path. Then someone else has to come and take care of it, and they've had their training for what they're going to do with it.
Yeah, and risk management is a great group to talk to, because they don't want whatever you're hired to do is you are hired to do that role in that place. If that is not part of your role, then that is not part of what the organization is obligated to protect you protect you. So if you're doing something outside of your role, even if you think you're being helpful, it's not necessarily going to be good for you, because that places the organization and you at higher risk for whatever issues may arise.
And we have another question here. Have you seen value in encouraging patients, staff to file grievances with the internal 1557 coordinator or outside entities?
I haven't seen it, but I think if people have concerns or complaints, and they look like rights violations, that they should be filed, because oftentimes these patterns of violations that happen are occurring in the same place, because you see that the same thing with medical error and that kind of thing. So I would say, yeah, there is value, but also making sure that people understand that these investigations often take a long time. And so it's not like going to be instant gratification and they're going to have an answer the following week. So that's, I think, because demonstrating a pattern of problematic operating policies is what triggers reviews by regulatory bodies.
So I don't know if interpreters are trained in how to file safety reports. Maybe they are, maybe that's the case. I don't even know that. But there's internal institutional type filing, external institutional type filing. And earlier I was advocating for the safety filing safety events. It could be near misses too. It doesn't have to be a disaster. Even a near event is something that your QI department wants to hear about. So this is not a direct answer to the question, but I think there may be faster and at your hand in the computer right in front of you mechanism to file safety or near event safety concerns, and then let QI decide if they want to run with it, and then separately have your leadership go and talk to the QI leadership and figure out a plan for how to make improvements, because they do want this to be working better, because they know that it affects their safety outcomes.
Yeah, and this is also helpful for, documenting cases where it seems like there was a problematic interaction that affected the patient experience with whoever was brokering the communication. So because, sometimes it's a single person, but, if someone's And this is especially important for women who may be in delicate positions around their health, and especially in certain states these days, of making sure that whomever is doing the interpreting is sensitive to whatever is going on.
And in regards to reporting any type of compliance or, issues or concerns that a patient may have or an employee, that's why we have the patient rights and responsibilities that are mandated to be posted in public areas and also on all the websites with the contact to your civil rights coordinator or your Section 1557 coordinator, however your organization chooses to list that person, so that people do have access to be able to make those complaints or address those concerns. And from my experience, any type of occurrence report is taken very seriously, is thoroughly investigated, not only by risk, but also legal, and then all parties involved. And there has to be a resolution to that, whether it's training that might be deemed mandatory, or it could be education that has to be provided, or all of the above. So I do think it's a worthwhile endeavor if you're seeing something, or if as an employee, or if you experience that as a patient, it's of course going to depend on your organization, but from my experience, anything that's filed as an occurrence is taken very seriously and thoroughly looked at, because they are reportable too once they're put into that system. When accreditation comes, at least under DNV, anything reported has to be submitted for review and seeing how it's resolved.
Yeah,
Well,
I happen to be a little sore about this topic of the rights and responsibilities documents, because actually what I see them used for mostly is patient control. You know, like you talked, you know, this whole movement started, you know, as patients' rights, but actually it's like kind of used to just kick people's families out and you know, get people in trouble. Like I would say more than 100 to 1, it's used for control as opposed to rights. Unfortunately.
That sounds like a very interesting topic for another webinar to dive into.
Well, it was a patients' rights movement, but as it was enacted, it became patients' rights and responsibilities. So the piece of paper can be put on everybody's, you know, in everybody's room, but you know, actually, what power does it have to, especially as Vanessa pointed out, with, you know, so many government agencies losing their staff. The typical way it's enforced is to kick patients' families out of the room, or to get someone in trouble for smoking or for spitting or for swearing, or I don't know. Allison, have you seen that kind of thing?
I haven't, but I'm also not, my engagement with clinical operations has largely been through research, so I have not been in the thick of it. But in my interviews for the study that we're doing, and we've done over 50, we haven't heard about, nurses haven't reported about those incidents, those types of incidents. So, but that's only 50 hospital nurses in
I
here.
see.
So.
Yeah.
Well, it looks like our time is up, and I want to extend a heartfelt thank you to our incredible panelists. Your insights, experience, and passion for advancing language access in healthcare has truly enriched today's conversations. You've helped us better understand not only the challenges we face, but also practical paths forward. So thank you for your time, your expertise, and most importantly, your ongoing commitment to ensuring every patient receives safe, equitable, and compassionate care, no matter what language they speak. Thank you.